to travel, journey, voyage, expedition, tour, pilgrimage, safari, odyssey, to boldly go where no one has gone before. Welcome to our podcast, Travel Unravelled, an ISTM podcast sponsored by the International Society of Travel Medicine and IMAT, the International Association for Medical Assistance to Travelers. How are you guys doing, Anne, Albie? Albie, I hear you're having some difficulties there in South Africa, some challenges with electricity.
I actually thought we're not going to make a political statement out of this. But seeing that you're giving me the opportunity, yes.
Okay, we can talk about the weather then. How's that? Anything new since the last time we chatted?
Yeah, since the last time we were together, I've been to New Orleans in preparation for the next ISTM meeting in 2025. That's exciting.
I just got back from Vancouver. My best friend got her pilot's license, so we were in this tiny Cessna 172. First time flying, taking off with her, a little bit scary. She's an oncologist that decided to get her pilot's license. But
fantastic.
So I'm here, I'm alive, didn't crash. That's exciting. I am very excited that we're talking about one of my favorite viruses, rabies. I just find it to be such a fascinating disease. It's terrifying, but it is something that is so interesting in the way it presents. So I'm very excited that we're going to be going through this today.
Aisha, I'm astounded. I always thought of you as a very nice lady. And I think the rabies virus is evil embodied. And you come and tell us it's one of your favorite viruses.
Well, it's just so fascinating. The history and the way it presents with the hydrophobia and the incubation periods. So I'm excited to get into this one a little bit more.
I agree with you. It's an absolutely fascinating virus. Unlike all the others we know that are spread airborne or food and water or whatever, this one gets into your body from a bite, and it actually grows into the nerve, up into the spinal cord, up into the brain, and finds its way from a sensory or a motor nerve down into your salivary glands, which is the way it gets into the next victim. That is absolutely fascinating. I don't even think artificial intelligence could have thought of that one.
And also the time, as mentioned, it can take months and months to have any symptoms. So it's very scary that way. You think you had a bite or a nip, you think you're safe, you don't do anything about it. And then if you wait too long and you get symptoms, you're done for.
Yep.
So it's very scary.
Well, I think the craziest thing about it is 100% case fatality rate. Like, that to me is crazy. In today's episode, we will be discussing the history of rabies, how it affects the body, why it matters to travelers. So we really want to know the context of rabies for travelers, top tips depending on where you might be going, where you might be exposed to rabies. And we're also going to introduce our two guests that we're very delighted to have on the podcast today. Professor Lucille Blumberg, who is the Deputy Director of South Africa's National Institute for Communicable Diseases and the founding head of the NICD's Division of Public Health Surveillance and Response, as well as Dr. Patrick Soentjens, who's the Medical Director of the Institute of Tropical Medicine in Antwerp, Belgium. He is actually quite instrumental in the world of rabies because he's really changed the way that rabies is treated, and we're going to get into that a bit further. And the other thing I learned about him is he used to be a paratrooper, which is also wild. And as always, we're really grateful for the sponsor of this podcast, Travel Unravelled, the International Association for Medical Assistance to Travelers, as well as the International Society of Travel Medicine. Right before we get into talking a little bit about rabies, we're going to go to our JTM Pearls. And today, joining us from France will be Dr. Olivier Aoun, who will be discussing infections that you can get from medical tourism.
That's very intriguing and scary. People don't realize what they sign up for when they decide to go abroad to get their medical care. But
like your butt in your butt lift. Joining us today, I have Dr. Olivier Aoun. He is a military field physician specialized in deployment related to health issues, military occupational medicine, and medical readiness of troops. So Colonel Aoun is going to be highlighting one of the clinical pearls today on multi-drug resistance on gluteal abscesses due to Mycobacterium abscesses, which is a type of bacteria, following medical tourism for cosmetic purposes to Mexico. Now, that might be a mouthful for some of you listening out there. Colonel Aoun, could you break this down for us a little bit?
Medical tourism has been increasing dramatically over the past 2 decades as a result of globalization. And we have an estimated 4 million medical tourists annually traveling to undergo these aesthetic procedures. So basically, it's like breast and gluteal augmentation, abdominoplasty, liposuction, the eyelid surgery, and rhinoplasty.
How common is this? In what countries are you seeing this coming back from?
I mean, currently, like common destinations for surgical aesthetic procedures is Turkey and Mexico. And in our case, there was an injection of hydrogel in the gluteus that was performed in Mexico. And it's the hydrogel that was contaminated by Mycobacterium abscesses. And the problem is like people always travel to these low-cost countries in order to have these aesthetic surgeries, but cheaper doesn't mean safer. It's cheaper because they don't have the same regulatory procedures that we have in Europe or USA. And sometimes drugs can be counterfeit or ineffective.
So do you think if somebody needed a procedure done that it would be worth traveling to another country potentially for what we call medical tourism?
As a medical practitioner, I always tell the patients what are the risks. They can weigh the risks and the benefits. But like personally, I would not recommend to travel for aesthetic surgeries because when it happens, it's very heavy and the patients, they pay this a very heavy toll.
So this article from the Journal of Travel Medicine is called Multi-Drug Resistant Gluteal Abscesses Due to Mycobacterium Abscesses Following Medical Tourism for Cosmetic Purposes to Mexico by Martinez et al. And this article can be accessed in the links section of our podcast for those of you who would like to do some further reading.
And if you're also interested, I have submitted a workshop for the next ISTM that will be in New Orleans and hope to see you there.
That's fantastic. All right, Dr. Aoun, thank you so much for joining us today.
Thank you, Aisha, for having me. See you in New Orleans.
And now switching gears back to something a little bit more mad and violent, rabies, which actually comes from the Sanskrit word rabas, which means to do violence, or in Latin, rabere, to rage, which, depending on the day of the week, might be appropriate.
Just mentioning where the word comes from, Sanskrit, that's a little bit further back than the Romans and the Greeks even. But interestingly enough, domesticated dogs, animals, but dogs specifically, have been associated with human beings as long ago as 4,000 years ago. And there's mention in Mesopotamia, which was close to where paradise was supposed to be in the old days in the Old Testament. There are mention not only of domesticated dogs, but also of something that looks and smells very much like this was rabies. So this is a virus that, along with animals and humans, have been around for thousands and thousands of years. It's a fascinating virus.
Rabies is really interesting because it's been used as a topic for scary books and movies. For example, in films like Cujo, based on Stephen King's novel, which depicts a rabid dog terrorizing a family. Rabies and vampires actually also have a really interesting intersection in pop culture where they both involve a transmission of a disease per se that alters behavior and leads to either aggression or death. This vampire lore, really reflects the act of being bitten by a vampire, and then the vampire can be seen as analogous to the transmission of rabies, where the bite of an infected individual leads to this transformation in the victim's behavior and physiology. So in some ways, rabies is almost a metaphor for vampirism. The symptoms of aggression, hypersensitivity to certain stimuli, the aversion to water, vampires light. And it really parallels some of the traits associated with vampires, which is quite interesting if you think about the interpretations and the way that rabies has really been depicted in a lot of pop culture.
So we know that somebody can be exposed to rabies or they can be infected with rabies.
Yeah, I think that for rabies, it can be a little confusing for people, because when you hear about rabies and you hear about people who have disease with rabies, it's 100% fatal. It doesn't mean that that dog bite or bat exposure is what's fatal. It's if you don't deal with it properly and go to healthcare, wash your wound, go to healthcare, get proper post-exposure prophylaxis, and ideally actually get pre-exposure or priming vaccine, so you never need to have the worry of so urgently getting to healthcare. You still need to deal with that wound. But we're all about really prevention here, preventing the dog bite or the exposure if possible, and then dealing with it promptly if you are exposed. So before we start, we just wanted to make sure we covered a couple of definitions. A lot of time in the interviews we talk about RIG, or rabies immune globulin, and it's important for people to understand what that is. It's giving protein that protects people or kills the rabies virus. We also talk about vaccine in different stages. So pre-exposure prophylaxis talks about giving the rabies vaccine before you have an exposure or potential exposure. And it's also more recently they talk about priming by giving those doses of vaccine so that your immune system is primed and ready to react if ever you have a bite or an exposure, and you just need more vaccine after that.
That's why we said earlier on, the virus doesn't immediately go into the bloodstream. It sort of hangs around in the tissue while it gears itself up to penetrate into, I think it's the neurolemma of the nerve root, to get in there. And that's the gap that we get, where if we can either put antibodies in there in the form of rabies immune globulin, so that's passive immunity, so the antibodies will kill the virus before it gets to the nerve, or we give a booster rabies vaccine because the guy's been primed, he's already got memory cells, antibodies that are sitting ready, but they need to be sparked to go and attack the virus before it gets to the nerve. If we utilize that gap, that's when we can prevent the person getting rabies. Although there's a rabies virus in his body, it can't get to where it wants to go and actually infect him, make him sick, make him symptomatic. It's that critical little time right at the beginning that we are given. It's not like when you inhale a COVID virus, it's in your lung, it's going to make you sick.
What we never want to see is somebody actually infected with rabies and with disease with rabies, because there's basically 100% fatality from that. What we want to do is get people, if they've had a possible exposure, to give them immune globulin or passive protein to protect them against that rabies virus, and a vaccine so that you make some more of that protection so that hopefully you never get disease. Ideally, what we'd like to do is actually get them before that, completely before any exposure, and use either, you can call it pre-exposure prophylaxis or priming. They're talking about more and more. So you get a couple of doses of vaccine so that you've pre-made, or your body's ready to make that protective antibody or protein if you're ever exposed to the rabies virus. So it's groundbreaking, I think, what's happening with respect to what we can do for prevention, and really puts it potentially in the arms of a lot of people who live in endemic areas where there's much more risk, and for travelers as well.
Professor Lucille Blumberg, Deputy Director at the NICD and founding head of the Division of Public Health Surveillance and Response. I had the privilege of talking to her the other day in my study, and Lucille told us about the first time she encountered a patient with rabies.
It was a young kid who came from Zambia, who'd been bitten by a dog, had not had the benefit of preventative post-exposure treatment, was comatose, there was a bit of delay in making the diagnosis, and died. And I think that made an impression. And I think the biggest impression was when I joined the Special Pathogens Unit at the National Public Health Institute, the NICD, And the first brain arrived in a little bottle of a young child. And I thought, this can't be. This is a preventative disease, and it's not treatable.
How can you get rabies when you're traveling, and what would be the biggest risk points for that? Because working as an emergency medicine physician, I've seen people come in, from bats, scratches or bites, people in their cottages, or somebody was chased by a dog down the street and got bit. But what about in the context of travel? Why is that important?
So I think one of the things to think about first is here in Canada, for example, everyone who has a dog gets rabies vaccine for that dog to help protect them from getting rabies. So in Canada, it's bats, as you mentioned, but in a lot of the world, there's many, many dogs around and they're wandering around and they haven't had rabies vaccine, so they're exposed to rabies. If you're one of those people who likes to bike or likes to run, you become a target for dogs when there's lots of dogs around, so you can easily get bitten. And, dogs, especially puppies, are cute, and many travelers are dog lovers, so they reach out to those animals not realizing the risk that they can have if they get a nip or a bite.
And the risks for rabies, I thought it's something like 1 in a million, right? We're talking about a very, very low risk here. But I guess when you're talking about getting bitten by an animal, I see that all the time in travelers. I went to feed the monkey and it bit me. I was walking down the street and I accidentally stepped on the cat's tail and it bit me. Or, I was exactly running, or I was biking down the street and a dog chased me and bit me. So I hear that a lot.
Prof. Lucille had a very interesting tale that related to a game ranger that had an encounter with a jackal that didn't want to come out from underneath his vehicle.
I received a phone call from, let's call him John, who was a game ranger in a game reserve in northern South Africa. He had taken a group of tourists out, and a jackal came up to the vehicle and started to bite the tires. That's very unusual behavior for a jackal. So it disappeared. He didn't want to upset the tourist by driving over it, so he put his foot out and he looked under the vehicle, and the jackal bit him through his trousers. So he took the first aid kit, cleaned it up, and drove off, didn't think very much about it. And then he actually did go to the clinic at the hospital, which was well equipped. But because the wound was not huge, it broke the skin, they gave him only vaccine. So he did the right thing on his side. They did not. They had Rick. And then about 2 or 3 months later, the animal was not found, was not tested. They found a hyena dead, tested it, and it had rabies. So now he thought, gosh, what about that jackal? And he called me and said, did I receive the right treatment? Is there anything I can do? And I have to remember that moment when my heart dropped to my knees, when I realized that the animal was rabid. Behavior was that of a rabid animal. There's rabies, not a lot in that area. And he got a little bit of wound washing, bit through his trousers, okay, and he got vaccine, but he didn't get Rig. So it wasn't, a complete treatment. And now there's no test. He could be in the incubation period. There's nothing more that could be done. So, yeah, the story has a good outcome. We're now 2 years and 9 months later, and he's fine.
And we're holding thumbs.
It may even be 3 years by now. And he's fine. He did clean the wound. It did bite through the trousers. He did get vaccine.
The hard thing is with the risk, if you're wrong, if you guess wrong and you don't give somebody protection after they've had a possible exposed bite, then there's 100% fatality. So there's a real balance with respect to risk and possible benefit of prevention.
It's not only about how much rabies is there around in the animal population, whether that's wild or domesticated or stray dogs. It's also where you are. If you get exposed, how easy is it going to be to get the correct post-exposure treatment? We know that rabies immune globulin is almost impossible to come by in most parts of sub-Saharan Africa. Lucille and I had a discussion about an adult that was exposed to a clearly rabid animal in a country just to the north of us. And he got all the right treatment on paper. He got rabies vaccine, he got rabies immune globulin, and he died of rabies 2 months later. Why did that happen? Because we're not sure whether the cold chain was maintained, whether the vaccine was given correctly. Was it given in the deltoid? Was it given in the buttock, so it never got absorbed properly? Was the rabies immune globulin given in time? Was it good quality? Was the cold chain maintained? Was it given correctly? And those are all the things that make it so much more difficult to decide who gets a rabies vaccine and who doesn't, but that makes you think a second time as to whether there's just a small risk of a rabies exposure.
As you describe sort of the pathogenesis of rabies, kids are often at the same height as the dog's face, so they often get bit closer to their head as opposed to adults who get it nipped on the finger or somewhere else or on the leg. And they often don't report the bite because they know they're not supposed to be touching the dogs. They know they're doing something they're not supposed to. And so there's a real concern about kids. They can actually have a much shorter incubation period because the virus has to travel much less to get into the brain. And so it's much more urgent to get that rabies immune globulin, get it into the wound to stop any spread of the virus and get that vaccine. So if they can get vaccine before, it gives the parents a lifeline for that child to get them to somewhere where maybe they can get safe, effective vaccine that is maintained in the cold chain.
I've heard that there was a case of rabies where clinically they presented like 15 years after they got bit. And you talk about missing a diagnosis. So what exactly is the presentation for rabies? What are some of the signs and symptoms that people would have to look out for, or how does it present in somebody who has been bit by a rabid animal?
So I think to take a step back, the important thing is to talk about what is the exposure and to address that. And as you said, the incubation period, or the time between when you're exposed to when you have symptoms, can vary very widely, even years. And oftentimes what people get is just some neurological symptoms initially, perhaps where the exposure occurred, and it may be numbness or tingling or some pain. And then that goes on to more extreme symptoms and the hydrophobia and other stuff we had talked about earlier, where people really go into spasm if you put water in front of them. But unfortunately, they recognize what they're doing as that's happening. They're awake and alert as they're having more and more uncomfortable symptoms.
Yeah, and those symptoms can include things like having fever, what appears to be seizures, abnormal movements of the limbs. There are some very interesting cases of people that contracted rabies. We said no human-to-human spread, but people have contracted rabies post-organ transplants. The donor of the organ was perceived to have died from a drug overdose. They were known recreational drug users, presented with strange symptoms, and when the patient died, they said, hey, this is a perfectly healthy person, otherwise let's transplant the kidneys. And the recipients died from rabies because the person, the donor, didn't die from a drug overdose, they died from rabies. So it's a huge, the presentation can be hugely confusing. And it goes back to Travel Medicine 101. History. Where have you been? What happened? And it might have been it could have been a rabid dog, but it could also be a bat scratch, a very minor scratch. So a scratch that breaks skin is, I think we refer to it later on, that's a category 2 exposure and needs, you go full out with a whole army of post-exposure management if there's been a break in the skin, especially if it's a bat where we don't always see the bite.
It's interesting you say that, Albie, because I think that's how they think that Edgar Allan Poe died. I guess his body was found in New York after he suffered hallucinations and periods of extreme aggression and lucidity. And he was an alcoholic, so they thought maybe this was DT, but they later realized that they think that it might have actually been from from a rabies infection. But you talk about categorization of bites, and you talked about category 2. Can you or Anne detail a little bit what you mean when you're talking about the categories of bites or risk?
So category 1 would be exposure to a known or a potentially rabid animal that didn't break skin and didn't involve mucosae, because you can get rabies from salivary exposure, so infected saliva from an animal with a splash in your eye or a splash in your mouth. I mean, we've had some ridiculous cases in South Africa where a person was in hospital dying of rabies, probably contracted from a pet animal, and the wife was allowing the pet animal to kiss her in this time while the husband was getting sick. And that was the infected animal. It brings about another, we'll stick to categories for now, but just to quickly remind our audience that there's rabid rabies, so animals looking and acting mad, but there's also dumb rabies, which is either wild or domestic animals that act particularly docile, that sort of, they're more tame than they used to be, which is when wild animals come up to people and look like they're friendly. So if you've had an exposure to an animal that you know or suspect to be rabid, and there's no broken skin, no exposure to mucosa, that's a category 1, and all you do is wash the area and do nothing more. A category 2 is anything that breaks the skin. There doesn't have to be blood, but anything that breaks skin or a mucosal exposure would be category 2. And category 3 is basically when it clearly draws blood. That's the really bad sort of scary movie lesions that you see. And a bat exposure is always category 3 because bat teeth are very small. I'm taught. I've never tried to examine the teeth of a bat, but you can get puncture wounds from a bat bite without actually seeing the wounds. So facial bites can have a very short incubation period from the time to exposure to the patient showing symptoms because it's so close to the brain. But our fingers have also got, millions of nerve ends. And so finger exposure and facial exposures can have short incubation periods for that reason. And that might be why he became ill and passed away so very quickly, because it was a hand exposure. If it was on a foot, those are the ones that can take months to years to actually show symptoms.
So as we know, rabies is low risk potentially for our travelers. However, the risk of being bit by an animal is much higher risk for our travelers, and as such, the risk of rabies can potentially be higher when they're traveling to somewhere that's endemic for rabies. So how would we prepare our travelers? How would you advise that somebody take proactive measures in managing their rabies risk and to decrease the chances of them being bitten?
When you're planning a trip, it's important to think about possible rabies risk. And I think that the work that's gone on recently has allowed travelers to have rabies vaccine more accessible because of decreased number of visits, decreased number of doses, and even how big the dose is for vaccine before you travel. You really need to invest in it. And it's a lifetime investment, just 2 doses and you're good for life, and never need the worry of having post-exposure prophylaxis with rabies immune globulin. You only need a couple of doses vaccine afterwards. So it really gives you a lot of leeway and security lifelong.
Great. Thank you so much for that, Anne. Now let's bring in our other guest, Dr. Patrick Soentjens from Antwerp, Belgium, who has been so influential in changing the way that we approach a rabies exposure.
Patrick, so we're going to drop the professor for now because you've already introduced yourself and we've known one another for a long time. I think we've got a nice surprise for our international members of the International Society of Travel Medicine. Wij gaan deze onderhoud voer in Vlaams, Nederlands, Afrikaans, sodat de Nederlandstalige lede van de vereniging ook kan deelneem hieraan. Nie net de Engelstaliges nie, stem jy saam?
Ja, dat vind ik een heel goede beslissing eigenlijk, ja, om het Nederlands of Afrikaans te spreken.
Afrikaans, Nederlands, maar ek sien 'n paar worried faces, so maybe we'll go back to English, Freaking colonials, what can we say?
I started in the military training because I studied via defense. And in fact, now I hold the rank of Lieutenant Colonel in the Belgian Defense Department. But 20 years ago, when I finished my medical studies, I was a fully trained paratrooper. We had some Belgian soldiers that were active in Mazar-i-Sharif in Afghanistan, and they were always associated with a German battalion. And they needed to be vaccinated against rabies, otherwise they couldn't join the mission. And for that, at that time being, they needed to follow a pre-exposure rabies vaccine before mission, consisted of 3 intramuscular vaccinations over 28 days, with a booster after a year, followed maybe by more boosters if they had more missions oncoming together with the German battalion. And I was thinking this is a very cumbersome regimen, very difficult to follow. Thus, we need a change.
What's the benefit to having all of your soldiers pre-primed with rabies vaccine? Because often you guys, I'm sure, like the Canadian military, travel with your medical team and stuff, and you probably have rabies immune globulin and vaccine available. So can you give us an idea so we can translate it to the regular traveler?
Yeah, we had a lot of issues about the pre-exposure vaccination schedule, but also the post-exposure regimens. The availability of immunoglobulins was not so easy in that time that I remember, but also the vaccine stock of only rabies vaccine was also in Belgium always very limited. To start pre-exposure vaccination, it was also not always easy in the military to start with it, what we did since 2009, because you needed a lot of preparation time. You need 28 days, and people are coming maybe once to a visit, but not 3 times. The same with the PEP regimens. People are coming maybe for the first 2-3 boosters, but not for additional injections. So we had a lot of practical issues in the military due to rabies PEP or rabies PrEP.
And it's really been groundbreaking and changed public policy worldwide. We went from needing 3 doses over almost a month to needing 2 doses, maybe with 1 visit in the near future.
So I think what's important for travelers to realize that if they've had a potential or an actual exposure to a rabid animal, think rabies, think could this be rabies? And if it is rabies, what do I need to do to get this fixed? Now, Lucille Blumberg spoke about that the other day as well. Let's hear from her.
The virus is in saliva.
Yeah.
It might be on the paws because animals lick their paws, but the virus will not go through intact skin. So whatever you have available, and out in the field or a rural area, you may just have water, you may have river water, just kind of lavage that wound very, very well. And it's something we should teach communities who don't have easy access to further management. Okay. And you may physically remove the virus from that wound.
So whether it's just a scratch or whether it's a deep wound, we actually want to wash that wound.
Yeah.
We don't want to scrub it because you may scrub the virus.
Take some soap and water if it's available.
Soap and water.
And wash it very, very well for 10 or 15 minutes.
And if you have a bottle of whiskey, you take a glug and then you use some of the whiskey to wash the rest if you haven't got enough water.
That's an Albie trick.
Okay, well, it
That's
helps.
Fine.
It helps. So now the wound has been washed. That's extremely important. And then the next thing that needs to happen?
Well, if they need to assess the behavior of the animal, why did that animal bite them? And for many incidents, it's because people are doing the wrong thing. They interfere with the animal, they tease the animal, they may have food that the animal wants, they may try and separate the mum from the baby. You know, those are animals behaving normally. Mm-hmm. Most animals with rabies, you know, will actually look ill. If it's a dog, they may be wobbling, they may be salivating, they may be making strange noises and crying at the moon.
But they're not always aggressive.
No, you know, domestic animals may become aggressive. Puppies are often very just fluffy. And wild animals may unusually become, unusually tame and they will approach you when they wouldn't normally, but they may become very aggressive.
Immediately you're going to seek local medical care because that's what you're dependent on. But you need to know the wound needs to be washed. It mustn't be stitched. It mustn't be scrubbed. It must be rinsed very well for up to 15 minutes, as I think Professor Blumberg alludes to, under running water. Doesn't matter whether it's clean. We'll sort out the other infections later. You then need to get rabies vaccine post-exposure, only 2 doses if you've had a primary series, if you've had your immune system primed before. You only need 2 doses, day 0 and day 7. If you did not have previous rabies vaccine, you need 2 doses, day 0 and day 3. And if it's a category 3, you also need rabies immune globulin given within 7 days of your first dose of post-exposure vaccine. And no matter what it takes, you need to make sure that you are capable of obtaining that, even if it means that you need to get on an aeroplane and go somewhere else to get that.
Say you're seeing a traveler who, when you talk about their last trip, they talk about an exposure that sounds like it may be a rabies exposure. Even if it's more than 3 months ago, you shouldn't ignore it. You should still think about giving them post-exposure prophylaxis if it was a significant exposure.
I think part of it is really the fact that this is a vaccine-preventable disease. And we actually do have a vaccine that is quite effective that can prevent against rabies. And it's not a new vaccine, is it? It's something that was developed back in the 1900s by Louis Pasteur. And even that story, the history of the development of this vaccine is so interesting. Albie, do you know a little bit about the history of how that vaccine came about by Louis Pasteur?
When Pasteur and his colleagues were trying to develop a vaccine against rabies, they realized that the work that they were doing was so dangerous and what would happen to them if they got exposed. So remember, they were trying to retrieve virus from animals, laboratory animals, that they knew were rabid. And so every day when they went in, I think there were 3 of them working together, every day when they went into work in the laboratory, they had a loaded revolver with them. And they had promised one another that should any one of them be exposed to the rabies virus, one of the others would shoot him. And that is like, wow, somebody was prepared to take that risk and to go that far, knowing what a horrible death they would die should they become exposed to the virus. When they first started using the rabies vaccine, on experimenting with it, they gave very, very small doses of the actual virus to animals and eventually to people. But the last vaccine in the series, and I think we're talking about up to 19 vaccines, if I remember correctly, the last vaccine actually contained fully virulent rabies virus. I don't think that's going to pass an ethics committee at this point in time. But that's how we got to. That was the sacrifice that was made in order to get us to the point where we've now got very, 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 very safe rabies vaccine. Which brings me to an important point. We're always careful when it comes to pregnant women. You know, we may give lots of vaccines to lots of people, but if somebody's pregnant, we don't. There is no contraindication to rabies vaccine because rabies is 100% fatal. So no matter whether you're pregnant or immune suppressed or what you are, if you've had a rabies exposure, you have to get rabies vaccine, and it's absolutely safe to do so.
I think Louis Pasteur actually initially first experimented on that 9-year-old boy, Joseph Meister, who was mauled by a rabid dog. And it was successful after about 13 vaccine injections that was given to this kid. And yeah, exactly. You think about, how would that pass ethics approval now? But at that time, he would have died otherwise. And I think that was kind of one of the success stories from Louis Pasteur. I think the other thing is that they were infecting rabbits, right? They were deriving the original vaccine from the spinal cord of infected rabbits, which I originally thought that's where the term rabid came from. I actually thought it was from the fact that they were deriving this vaccine from the spinal cord of rabbits. But as we know, that's not the case.
You've now had a classical education, so you now know that it comes from the classics. You were mentioning Joseph Meister. I mean, this was in the late 1800s in Europe, which is not that long ago. And I think we forget that the first world, the developed world, the classic world, they were exposed to this. Now we tend to think of rabies as something that only occurs in developing countries and, sort of out there in the dark. That's not true. And I, being an African myself, I'm a bit touchy about the fact that, people who come to Africa should get rabies vaccine, but not necessarily people going to Europe. We must just remember that there's terrestrial rabies, which is prevalent in many places of the world. But then there's bat rabies, which it's not the same virus, the purists will tell you. But you know what? If you get bitten or scratched by a bat, you're going to die from something that looks and smells just like rabies, and it is preventable by the rabies vaccine. So, that's just a little bit of context. And then the other point is that with the reintroduction of wildlife, which is all part of all of us agreeing that we would like to, save our planet, with the reintroduction of things like bears and wolves in parts of Europe, and even in the Americas, there's the risk that rabies will come back in those populations and be present in those populations. And that's why it's so important that we vaccinate the animals. Our domestic animals must be vaccinated. And unfortunately, some people are lax about that, but this is a wonderful example of One Health. If we look after the animals, if we vaccinate the animals, the people are protected, and vice versa. So
they call me anti-vaxxer, anti-vaxxer, and so I like to focus on vaccinating travelers before they travel in prevention. And one of the biggest challenges I have when people come into my travel clinic is sometimes the cost of the vaccine, because in Canada it can cost anywhere between $200 to $300 per dose. And so I like to tell people to approach rabies pre-vaccination as almost like a travel insurance, because it's something where, yes, you're paying into and something you may not ever need, but in the case an emergency arises, you have that protection in a situation where you might not know. Vaccination is a really strong point where travelers can really protect themselves against this disease. What other suggestions or points or takeaways would you want to give your traveler in regards to decreasing the risk of getting rabies?
So I think that one of our guests, Patrick, has made great headway with respect to this, because as you said, the vaccine is remarkably expensive. And in Canada, we often give it intramuscularly, which is a large dose, very expensive. The newer regimen for the vaccine has taken it from 3 doses over up to a month to 2 doses over a week, and using intradermal or into the skin as the mode of delivery, which costs 1/8 to 1/10 of the price. So it really makes it potentially accessible to travelers. And just as you said, it being insurance, it's insurance for life. So it's a one-time insurance payment for life. The other thing to remind travelers is that you take care of the wound. This is a virus, and viruses break down with soap and water most of the time. So you make sure you clean the wound well. You do good first aid as you go to healthcare to figure out if you actually need primary vaccine if you haven't had it before, and immune globulin, or if you just need 2 doses of vaccine after you've been potentially exposed.
The other thing that I always tell my travelers, especially if they're traveling with kids, and as you mentioned, that kids tend to be higher risk for exposure because they're just lower to the ground and lower to animal exposure, and they're more likely to go and pet an animal, is to not pet and feed stray animals, and to keep your distance away from them, and to kind of scan where you're walking and where you're going to be a little bit more alert of your surroundings. I think those are all equally good tips for travelers, especially those animal loving people who go and pet and feed all the animals. And I think for them, potentially, giving them the pre-exposure vaccination is also more important for those who are going to be higher risk.
Both of you refer to insurance this and insurance that, but I've had two bad experiences with international insurance, one from an Israeli visitor to Malawi and another one from an American visitor, also happens to be in Malawi, where the insurance does not cover rabies post-exposure treatment. They were not prepared in both cases. First of all, they can't find or source rabies vaccine post-exposure. They couldn't find rabies immune globulin. And in both instances, the only solution was for the bite victims to fly commercially 2.5 hours to South Africa to come and get rabies vaccine and exposure. And the insurance and the assistance company were completely unhelpful, saying it's not an immediately life-threatening condition because there's no proof that the animal had rabies. You can't sit and wait until the patient's got signs and symptoms. Now, in both cases, there were fathers with big pockets. The one happened to be an American physician. And so they could afford a ticket and the cost of the actual post-exposure treatment in Johannesburg, and then try and claim it back and probably get a rabid lawyer in America to sort out the insurance company. But it's scary that at face value, and unless you are really insistent about it, insurance companies may actually decline cover for something like rabies post-exposure vaccination. And then the cost of pre-exposure just disappears in the face of having to pay for international air tickets and disrupting or ending a holiday in order to get the correct management.
Absolutely. And I think that's one of the cases in favor of pre-vaccinating someone before they go traveling, so that you take that sense of urgency away, and the fact that, yes, you may not have access to the post-exposure treatment where you are. It may not be covered, and it may mean that you need to go somewhere else to try to access it, and you may have to pay out of pocket for it. So if you compare that with the cost of the vaccination itself, then it may be a cost-benefit analysis to actually pitch that in and create, like I said, I tell people, make that your part of your travel insurance, because you never know. It's one of those you never know situations that you can't prepare for.
So the other thing I say is get it as a present for your birthday, or a present from something else, from somebody in the family that wants to keep you safe as you go on your travel, for the young kids who don't themselves have deep pockets for their travel, but they're likely to be at risk. The other thing is just to say again, I think what Albie brought up, not only is it the anxiety about trying to procure or find the immune globulin and the vaccine, but even if it's available in some parts of the world, there's no guarantee it's going to be effective. And I would argue, if you're in that part of the world, maybe you shouldn't be using it. If it is effective, maybe it should be used for the local population instead. So if we want to be sort of, conscientious or ethical travelers, we can also think about not putting that burden on the local healthcare system.
So Anne and Albie, you guys have had some fantastic conversations today with Patrick and Lucille. What would you say have been the highlights, or what would be your takeaway messages that you learned from them?
One of the most exciting things that I think Patrick alluded to was that the World Health Organization has got a goal of eliminating dog-mediated rabies in humans by 2030. I think it's a very ambitious goal, but let's all put our backs in behind it.
I think you're right. It's quite an ambitious goal if you think they're going to do that in the next 6 years. But certainly with organizations like Gavi working to provide immunization in endemic areas, that'll help.
The most cost-effective intervention for preventing rabies is to vaccinate dogs. And as soon as you have good coverage in dogs, the number of cases in humans and exposures will go down.
Absolutely.
So let's not forget that.
Yeah.
If I had all the money in the world, that's where I would put my money.
Yeah.
Actually. Vaccination of dogs. It's the most common exposure and responsible for the majority of human cases in Africa and Asia.
Patrick also had some important take-home messages. Travelers, let's see his take on this.
The first is certainly increase awareness in the traveler. Right? So that is really important. The risk of a bite is very high in endemic regions, and thus you need to be primed. And I think the best priming pre-exposure is with a 2-dose regimen for the moment. because most guidelines are stating that you need a priming with 2 doses. It's not so important that it's over 7 days. It can be over 28 days and even longer. And then also I want to state that less can be more. It's better to give one visit rabies prep regime before traveling than nothing at all. That are the 3 recommendations I have.
For Patrick's side of things, I just think it's remarkable the amount of time, effort, and success that his group have had, looking at how little vaccine you actually need to be protected, and then translating that into changing public health policy really worldwide, which is just remarkable, not only for travelers, but for the people who live in endemic areas to help protect them.
Yeah, and I think from my chat with Lucille, with the fortune of experience she brings along, it's think rabies.
Well, I think all post-exposure prophylaxis needs to be given as soon as possible. There isn't a window. You have no idea at what stage the virus will enter the nerve. And if it's a bite on the face or bite on the tip of the fingers, which is very innervated, it can be quite quick.
We could add once it's washed properly under running water. Don't scrub the wound because we don't want to scrub that virus in. Mustn't be stitched. And then apply iodine, or if you have nothing else, 70% alcohol, which you may have rather than iodine around because that's got antiviral properties. And then you've got to get your rabies vaccine, preferably today, but within 48 hours is critical. And once you've started rabies vaccine, if we're talking about a category 3 exposure, the rabies immune globulin must be administered within 7 days of that first dose of post-exposure vaccine. And this is what makes it so difficult when somebody is in a remote area to actually get all of those timelines in. So if you're planning a trip in the foreseeable future and you would like to know whether rabies is a risk in the area that you're going to, we will be posting a list of reliable resources that we like to use when making a decision on the risk for rabies in a particular region. I think what we need to know is that there's bat rabies virtually everywhere in the world, with the exception of some boring places like New Zealand and a couple of other Pacific islands. And terrestrial rabies is a particular problem in sub-Saharan Africa, parts of Central America and South America, Southeast and Central Asia. But there's rabies everywhere in the world.
So Albie and Aisha, that was a lot of fun. It's time for us to sign off. Do you have any final words?
I would just like to know what your trip to New Orleans was like. I think you've just been down there on the planning committee, and I'm wondering about whether it's worth the trip all the way from deep dark Africa to down under in New Orleans.
I think it's well worth the trip. The conference of the ISTM is always a great experience, a great way to see all your friends and colleagues. And New Orleans is fantastic. People are wonderful. Food is amazing, and the music, you really can't beat it.
Okay, you can't beat it. No pun intended. Yes, networking is always one of the wonderful things at the ISTM conference, and we're looking forward to seeing everybody out there.
So that's a wrap for this episode. Thank you to our sponsor, the International Association for Medical Assistance to Travelers, located on the web at iamat.org. Don't forget to follow Travel Unravelled on Spotify and on Apple Podcasts or on your favorite podcast platform. We'll post fun clips and extra resources on the ISTM website located at learning.istm.org/podcast. We're also on Facebook, LinkedIn, X, and Instagram at _ISTM_. Travel Unravelled is brought to you by the International Society of Travel Medicine. Our hosts are Dr. Albie de Frey and Dr. Aoun McCarthy, President-elect of the International Society of Travel Medicine. Today's Journal of Travel Medicine Clinical Pearl is featured by Dr. Olivier Aoun from Paris, France, and I'm the podcast director, Dr. Aisha Khatib. Finally, and thankfully, Travel Unravelled is produced by Ghost Bureau out of Toronto at ghostbureau.com.
Please remember that the information presented in this podcast is intended for educational and informational purposes only. It should not be considered medical advice, nor is it intended to replace consultation with a qualified healthcare professional. The views expressed by the host and guests of this podcast are their own and do not necessarily reflect the opinions or policies of the ISTM or any medical or other health professionals, hospitals, clinics, or healthcare facilities. While we strive to provide accurate and up-to-date information, the medical field is constantly evolving, and there may be new findings or developments not included in our content. We encourage our listeners to consult with their healthcare providers for any medical concerns or before starting any new treatment. Neither the ISTM nor any of its affiliates, sponsors, producers, hosts, or guests are liable for any direct, incidental, consequential, indirect, or punitive damages arising out of access to, use of, or inability to use the content of this podcast, or any errors or omissions in the content hereof. By listening to this podcast, you agree not to use this information as a substitute for, nor does it replace professional medical advice, diagnosis, or treatment. Always consult with your healthcare providers for guidance appropriate to your specific health situation. Thank you for listening to Travel Unravelled. We are committed to sharing knowledge and fostering discussion in the pursuit of better health and well-being.